and good evening, and welcome to this week's edition of Maternity and Midwifery Hour. This is number 12, I believe. I can't believe it's already at that number. And tonight we're looking at changing times with COVID-19, ensuring women's choices. And we can assume that a choice includes the partner's choices, but women's choices come first, as always. Plus, looking at midwife-led units in the MU network. And I'm delighted to have Lucia Rocca-Ihenacho. Am I completely wrong, Lucia?
Ihenacho.
I'm just going to call her Lucia now. And Sheena Byrom, who's going to be talking about supporting women's choices. My name's Sue Macdonald, and I'm the curator of the Maternity and Midwifery festivals and these hours. And it's my pleasure to be with you this evening chairing. And really, these sessions came about because of the COVID crisis, because you can't have face-to-face events. We really wanted to provide something for midwives, for student midwives, for doulas, maternity care support workers, anyone who is working in maternity care, to have some additional continuing professional education, have some information about what was going on out there, and not be so isolated, because that's one of the problems at the moment, I'm sure. And so we designed them, and huge thanks to Matflix, who have been doing the video streaming. This is from maternity experts who do the revalidation records and materials. A fantastic place to get any CPD if you happen to be looking at revalidation for midwives out there, or for students just to catch up on certain topics. There's a huge portfolio of material to be accessed. So, as I said, tonight we're looking at the impact of COVID-19 on women's choice and on midwifery-led units. And we have Lucia and Sheena. And I'm going to just start and put each one on the spot and ask them for a moment of the week. Shall I start with Sheena?
Okay, so the moment of the week for me was actually today. Hello, everybody. And that was because many of you will know that I'm the joint owner of the Practicing Midwife Journal. And our July issue was released today, published today. And this is the cover. And it's all about climate crisis and caring for our world. And it's about COVID-19 too, because we've been doing exceptional things during COVID-19. So why can't we do it for sustainable midwifery and sustainable world? So it's just an incredible front cover, and it's caused a big stir online, and we're just full of joy because of it. So I've been really excited all day. So that's mine.
And that is beautiful, the greenness of it and the beauty of it. It's lovely that some good things come around this time to bring our spirits on. How about Lucia?
Well, I think my moment of the week is that today I started my master's optimal birth module. And, I was quite anxious because normally my module is a very hands-on, workshopy style intensive week. And we are really concerned about, still recreating that experience for the students. And today we had the first tutorials online, and it went beautifully. All the students were so engaged. And so I'm so grateful for their collaboration and, the positive feedback, because everyone has been working so hard to make sure the students are well supported. So I was really, really happy.
Wonderful. Well, congratulations on the course. So these are two bursts of things, which is lovely. It's lovely. Thank you so much. That's a lovely way to start. I usually start at this point just to record our solidarity, really, with everyone in the health sector who's caring for people with COVID, or who are looking after family members who might have had COVID, or who have been affected in some way. And for those of you who haven't been able to be working in the health service, you're still valued, you're still there, and you're still important. And also a real big thank you to all the NHS and the key workers and their families, because everyone is contributing at the moment. And I think what's been very interesting for me this week is the discussions around the key workers and how they perhaps aren't the people we thought they were before this emergency and crisis, because everyone from the people who are providing food in the shops, the lorry drivers, the rubbish collectors, the postman, all of those people are key. So it kind of makes you think, actually, just about everybody in the community is a key worker. I'll pop that into you to think about. Anyway, I've got some little news. I'm expected to have a little news snippet. Right, the NHS has 72nd birthday on the 5th of July, and there's various things that are going on Twitter about whether there should be an applause or whether you should stop and raise a glass or a cup of tea. I think what's important is we all celebrate in some way, whichever way is appropriate to us, to think about how precious our NHS is and how we want to retain all that is good in it and all look after all of the people who work in it, how they should be looked after. And on this issue around the COVID lockdown, as everybody will know, Leicester have had a bit of a lockdown because they've had some increased rate of COVID cases. And interestingly, we were due out to have our festival there in a couple of weeks, and our minds were very much on Leicester. So we're with you. Our solidarity is with you, Leicester, because it's very difficult psychologically to have to be unlocked and then locked up. But your time will come to be released from what you're being tied down for. Also, just to raise awareness, there's new guidance from the RCM on face coverings for women during labour, and that's on the resource sheet that will be available online later. I wanted to also highlight the best tweet of the week. That's my choice, by the way. There's lots and lots of lovely tweets, and this was from Leah Brigant, highlighting corona babies, which is a group of parents who've birthed over the last few lockdown months. Very positive, and I think at this sort of time it's very easy to get swamped with negativity, and we need some positive as well, but not just positive for the sake of positive, but real positive materials. And just to finish off the news snippet, Dr. Tracy Cooper has been appointed Regional Chief Midwife for Northeastern Yorkshire. And you'll remember, if you've been joining us for these hours, that Tracy joined us a couple of weeks ago, and we're really pleased that she's been appointed. So having these regional chief midwives is so important for midwifery, our profile, and for maternity care generally. So that's fantastic. Well done, Tracy. Okay, so in this programme, we're going to look at the effect of COVID-19 on maternity services and the effect on women's choices around birth. Plus, and that kind of brings in, I say plus a discussion, but really it brings to the fore midwifery units and midwifery-led units. So I'm really so pleased to have the two speakers, perfect speakers I could have today. So firstly we have, and they're going to do a double act, and I should mention that right at the start. So that'll be really fantastic for all of you out there. So firstly, we have Dr. Sheena Byrom, who is a midwife. She's also has an OBE. She's the director for All for Maternity. She's obviously a midwife who's worked in so many roles in the NHS, including as a head of service and as a consultant midwife, and now as the owner of the Practicing Midwife and the allformaternity.com platform. Again, there are links on our resource pages for all of these, so you can go and check it out. And that's really the go-to place for maternity workers to learn, share and care. And her passion, well, she has a huge amount of passions, but the ones that I'm very aware of is her kindness, compassion and respect in maternity care. And Lucia is an NIHR research fellow and lecturer and researcher at City University in London. She's also the Chief Executive Officer at the Midwifery Unit Network, and she's also been a consultant midwife in her history. And I would say she is very much a fantastic influencer, and an influencer par excellence, because I think when you start listening to what Lucia has to say, you'll find that you want to listen and you want to get involved with the network. So welcome to both of you, and the screen is now yours.
Oh, brilliant. Thank you so much, Sue. Thank you for that wonderful introduction to both of us, and hopefully everyone will be able to see both Lucia and I on the screen together, because we're, as Sue said, we're going to do a double act this evening, because Lucia and I are very good friends and we have known each other for a long time. And during that time, we've kind of developed all sorts of things, but I just want to ask Lucia to tell you about that, because there's a little story behind how we met and how we've kind of come to be together tonight to be with you all.
Thanks, Sheena. So I'll tell you a little bit the story of Felipe and I. You see the bearded midwife there is Felipe Castro. Felipe and I, at the time, we were working at the Barkington Birth Centre in London. And we started getting connected with other birth centers, and very often birth centers were struggling to be recognized, to ring fence autonomy and staffing. And but by talking to each other, we started having the idea of the need of a network to support each other, to share best practices. But here we were, two foreigners in England, and we felt, okay, here we go. We have a great idea. We think this is something, but we really need some support from someone who has, connection, is well, is an influencing person, and can help us in moving in this very difficult field. So here we go to the Normal Birth Conference. I think it was 2014. My daughter was 2 years old, so she came along with me, and there we meet Sheena. And when Felipe and I met Sheena, we were like, okay, she is our woman. We really need to talk to Sheena about supporting us with this idea, because we have an idea, but we have no idea how to move it forward. And there we go. So I think probably Sheena thought we were some couple of crazy people getting, getting ideas firing up. And we contacted Sheena. So I don't know, Sheena, what you felt when we came and say, look, we have this idea. Can you please help us?
Well, I remember getting the email from Felipe, and I remembered him because I'd been in his talk in the conference, and he said, we'd really like you to join us. And I was very honoured, actually, and felt delighted, because it is a big passion of mine, birth centres, which I'll tell you about later. But yeah, I was really excited. And then, of course, I came to London. And the funny thing about this photograph is that just about 10 minutes before, I was walking along the street with my husband trying to find Lucia's house, because this was taken in her house. And my husband, Paul, said to me, what are you doing? What are you doing in this house? Why have you come here? And I said, well, I don't really know, but I'm just going to find out. I don't really know what the ins and outs are anyway. So that's what this lovely photograph is. So it's all those years ago we met, and I remember you baked a cake and it went wrong.
Oh gosh, it was so wrong, that cake. You were really...
So that's how we met, really, isn't it? And the rest is history. So, and then we start. One of the things I suggested on that meeting was that we had a website as a hub, and then we developed Facebook pages, groups, Twitter account, and the rest of it. And said, sort of the Facebook needed to be the central point. And we also invited Mary Newburn, who is an expert. She would call herself a parent advocate. And she's somebody who's a really good friend of mine, and we've worked closely in the past. So we felt that it was really important to have a consumer view on the group. So we invited her. This was actually in my garden in the north of England. We created a website. I built the website. We created a logo, we ran a competition, and it was all grassroots stuff. We just worked really, really hard. We got the RCM on board, and we moved mountains, really. This was a photograph taken when we were off to have a drink at a near bar where I live, and just showing how we had to do everything really quickly on the go, speed working all the time. But we did it, and that's a great thing that we did together.
Yeah, Philippe and I couldn't keep up with you too. You were walking so fast. That's why we took the picture, because we were struggling. We turned around and took a selfie. So,
and I suppose the story is Lucia is going to tell you now what's happened with the EmuNet from then to now. And I hope it inspires others, because we're a group of individuals who just believed in something. So, well, it was really Lucia's idea, of course, and Felipe. But once she got me on board and Mary on board, we all believed in it. We were all passionate about it. And so what's happened now is that there's this huge, powerful organisation that's supporting individuals all around the world. And it all started with that simple idea, gathering people together and making it happen. So over to you, Lucia.
Absolutely. And for me, that is so important, because you can have all the brilliant ideas you want, but they can remain just ideas. And I think by getting together with the key people, that's how you join forces. And none of us alone could have ever achieved what we have achieved in these 5-6 years. And I think to have a grassroots movement and be a group of people is crucial, because everyone brings in something. So from there, we started, moving on from the core of networking and influencing. We started developing training, which we are running, well, at the moment, mostly online. But we have reached more than 500 staff, both midwives and obstetricians, across England and Scotland, and more than 500 across Europe. We deliver training in several languages, because the team of facilitators speaks many different languages. We do consultancy on how to set up new birth centers. So it's really exciting, because we have countries where birth centers did not exist. And we have done, long-term partnership to really push things on agendas. Of course, within, being researchers, we are sitting also within City University. So there is a brilliant collaboration there on the topic of research. And of course, also in partnership with City, we have developed the European Midwifery Unit Standards, which was originally, the idea was to just, revise the RCM standards, and we finished doing in 1.5 years project, completely rewriting them, because of course we expanded from UK to Europe. So that was quite a massive project. So really exciting, and really a lot of learning going on. Loads of people, so you mentioned Tracy, and as well as Chantel with Stanley, they have been completely instrumental in supporting EmuNet, as well as so many others, including Kathy Warwick and Catherine Guttridge, and so many others. So really, everyone chipped in to help, and absolutely important. The standards, you can download them from our website, midwiferyunitnetwork.org. And we are now working on several translations. So loads of projects going on. And also, very importantly, we've been organizing conferences. Sheena has chaired this conference in Barcelona. I don't know, Sheena, if you want to say anything about that.
Yeah, I'd love to say something, because I use this photograph a lot in my talks when I'm demonstrating leadership, because Lucia led this event, and I just spent most of it in tears, because I couldn't believe the constraints of some of the midwives around Europe and the rest of the world they're having huge constraints in practice. They all came together from all different countries, and listening to their advances that they've made in their country because of the Midwifery Unit Network, and because they've been connected to Lucia and her team. And so my husband took this photograph right from the top of the balcony, and I can remember feeling overwhelmed, because I was stood next to him, thinking, this is an incredible sight. And the conference was it was probably one of the best things I've attended in my whole life. And it was because of that, hearing midwives have huge, huge difficulties in practice, to practice midwifery-led care that we take for granted sometimes. And they were talking about the small changes they've made that really were just tear-jerking. It was just wonderful. So yeah, amazing stuff, Lucia.
And I think, in a way, Midwifery Unit Network is a catalyst.
Yeah.
It's about sharing what works. Also, sharing courage, because, I think we've learned a lot of these from you, Sheena, about courage. And we had stories of midwives, they put, their career, they even risk to be arrested sometimes to provide choice and personalized care to women. So it's absolutely incredible. And of course, this gives us so much energy back in terms of, always reminding ourselves why we are doing this. And it was inspirational. And very, few months after we repeated this, we translated the standards in Italian. This was an amazing project. 1.5 months, the standards were translated and printed. And the amazing lead midwife for Milan and Bergamo, the most hit area from COVID, actually, she put together, in collaboration with the university, Bicocca, the most amazing conference. We had 600 midwives there. And again, Italy is a very traditional, very obstetric-led country. And to see all these young midwives really inspired to push on the change, it was really touching. So really, this is just a little, snippet about, why we do what we do. And I think to wrap this up and to move into, why choice, and we'll also talk about choice in the context of a pandemic. This is my niece. So she's the first woman in our family to have a completely physiological birth and to have the option to give birth in a birth center in Italy. My sister had very traumatic experiences. My mom had 3 C-sections. She doesn't even know why. And, sometimes I use this picture a lot because I always say, when you do also research, networking / activism, it takes so much time from your family. And for me to see my niece and thinking that actually perhaps the work I've done has contributed a little bit because Italy, now has birth centers is amazing. And she had the most amazing undisturbed birth ever. And I use this picture everywhere to encourage women because if they have been able to do it in Italy, they can do this everywhere. And it goes all back to choice. And I think you're very passionate about choice as well, Sheena.
Yeah, so I am. And the reason why I'm so passionate, and I'm just going to be brief here. So why we kind of like are on the same mission, Lucia and I, is because, Lucia, can you move the next slide? Can you move it to the next slide? Is because when I was a young midwife in the early 1980s, I went to work here it wasn't called a birth centre, but it was just like one. It was a GP unit. So it was where midwives could work caring for women away from the hospital. This was actually 10 miles away from the host unit. And I went there in 1980, and I was actually I'd only worked in obstetric units, and I just thought that I thought that obstetric care that I'd seen and experienced in a time when it was all active management of labour from O'Driscoll, and that I thought that was normal. I thought that was absolutely fine, and so I kind of thought that it was just normal to be in a hospital. And when I went there to this particular maternity unit, it was just incredible. And I saw women giving birth in different positions. They were stood up, they were moving around, the midwives were just watching. And then that choice was taken away from them because it closed down. And so sort of then over the years, I saw how the medicalisation of maternity services really kind of influenced the way things were going. And I saw the trauma that some of the women, I started a service for women who'd had traumatized births, and that really, it affected me more than anything in my career, I think. I'd never heard anything like it. And then, of course, just towards the end of my NHS career, I helped to create birth centres. I helped to develop them, which was just, sort of like for me, that working in the birth centre right at the beginning was a catalyst. But it was the fact that women had a choice, and when that choice was taken away from them, and they didn't have anything at all except it was just pot luck. I just felt that it was, so wrong. So that's why I'm so passionate about choice. So I made this. So because I'm so passionate about choice, over the years I've kind of got more and more involved in the choice agenda, and I kind of created this little acronym, this little mnemonic, which really kind of is great to keep in your pocket. So any midwives or doulas watching or student midwives, I can put this on as a PDF on the Facebook page that you can download and keep it in your pocket afterwards, because it really is kind of, you know, just the culture matters. Wherever a woman's giving birth, you know, it kind of makes a difference to what choices she has. And midwives who are working in services really contribute to that culture. Human rights should always be respected. Opinions, we shouldn't really offer opinion unless we're particularly asked for about something, and try to focus on wellness rather than risk. That every woman should be treated as an individual, because what's important to one is not necessarily the same for another person. And that courage is, you know, Lucia's talked about courage, and I think that courage comes from compassion, that the more compassion we try to connect with, the empathy that we have for women and birthing people and their families, then we're more likely to be courageous to support what they need. And we have to be courageous in being advocates for women and families. And evidence, accessing evidence and understanding evidence isn't always easy. And that's one of the reasons why I'm particularly excited about having the Practicing Midwife, because that's what we try to do, translate the evidence. But when you really, all of us as health professionals should understand how to find the evidence, how to critique it, and then how to put it into practice. And if you could put the next slide on, please, Lucia. One of the little resources I found useful was written by Kirsty Coxon, and it was published in the NCT Perspective of several years ago. But this is taken from the NICE guidelines. This is part of the article. And this was from the patient experience in the NHS, really giving you direction on how you should present the evidence, and how, you know, so once you know it, once you know the evidence and you have those facts clear in your head, then how you articulate that to women and families is really important. And one example of this is using absolute risk rather than relative risk. So saying that a chance of something happening increases from 1 in 1,000 to 2 in 1,000, rather than saying, oh, the risk doubles, you know. And that was once said to my daughter when she wanted to have a VBAC, was, oh, but the risk doubles to the baby. And my daughter, luckily, is a midwife and said, yeah, but it goes from 1 in 1,000 to 2 in 1,000, which is really tiny. But when you say it doubles, it's enormous. And the other thing, if you could move onto the next slide, Lucia. The other thing is that guidelines are guidelines. So, you know, the evidence that's developed, so guidelines are created based on evidence, based on population-based evidence. They're not really for individuals. They're there as a guide so that the practitioner, the healthcare professional, can present the evidence, and that the person who's listening, the service user, can make a decision based on those guidelines. But one of the things that I see all the time, and I hear student midwives talking about this, and midwives saying, oh, but the policy says women can't do this, and the policy says, and actually the guidelines are not policies. Policies are things like the uniform policies, and protocols aren't guidelines. Protocols, you have a protocol for something like an IV infusion if a woman's being induced, you know, a protocol for syntocinon. But guidelines are guidance. They're not tramlines, they're guidelines. And the reason why I've put the book The Roar Behind the Silence up is because there's a chapter on there by an obstetrician called Rinika Schramm and a midwife, a consultant midwife called Julie Froelich. And they've written a brilliant chapter on exactly that. And I think that every single healthcare worker should read that chapter. And also to understand the Montgomery ruling as well, because really that kind of, you know, that is the benchmark now for how we present evidence, how we use guidelines. And what that says is that actually the evidence that we give has to be relevant to what the woman wants to know. So she, you know, it has to be in perspective of her kind of her perceptions of or her particular condition, her particular concerns or her desires. It has to be centered on that, the evidence that we give. So yeah, there's lots of resources out there, and I think for all of us, we have got an absolute, it's critical and crucial that we understand that these are guidelines and they're there to help women make their choices. It's not about our choice, it's about her choice. And again, that brings us on to decision making, which is, I'm going to pass over to Lucia again, because that's another thing that we often hear people talking about, shared decision making, but that's really not where it should be. So I'll pass it on to Lucia.
Thank you so much, Sheena. This is such an important aspect. So for me as an academic, previously as a consultant midwife, but working now a lot with undergraduate and postgraduate midwives, the concept of women's autonomy, personalized care, and what we called partnership in decision making is so important, because we hear quite a lot talking about shared decision making. That gives me the creeps to talk about that, because the decision making is not shared. The decision making belongs to the woman. What we do, we get in partnership with the woman to discuss information, to provide support, but the decision belongs to the woman. So this is very important for me to distinguish the concept of partnership versus shared decision making. And I'm sharing this picture with you because we have developed an e-learning module based on this, as well as a lot of the evidence. We've got birth rights, little snippets of videos there to help us navigate the evidence. We also have women's stories of opting for so-called out-of-guidelines care, and is a very, very, I think is a very comprehensive module for midwives, but also obstetricians to really explore more this topic. And you can reach these via our website. There is the whole education area there. So, and Sheena, I pass back to you because I think you did this.
Yeah, I just created this little meme a couple of years ago. Well, not a couple of years ago; it's last year. Really, our president of the ICM, Franca Cade, she urges us to, really be true advocates for women and not to be afraid, and sometimes, to stop kind of being fearful of everything, but we are there to facilitate choice, and we are there to ensure safety. And we're going to come on to a little bit about what safety means shortly. But it is our position not to make decisions for others, but to facilitate that choice. And what she's saying is, every woman should have a good birth, and we're there to advocate for that.
Absolutely, Sheena. And I think ultimately, it goes back to who do we think we are as midwives? Where is our loyalty? Is our loyalty with women, or is our loyalty with institution? So are we defending the industrial model of birth, or are we there standing next to women and advocating for them? And at the moment, I see more and more in the midwifery world, some midwives getting lost in terms of their identity as midwives. So it worries me a little bit. So shall we move on to, so we'll now move on, and you see hopefully how the whole thing comes together, and why we talk about birth centers and why we talked about choice, and what that has to do with the pandemic. And when I talked to Sheena, I thought, can we give these, a slightly different cut to the discussion? Because for me, I'm looking at what's been happening in terms of care for women during the pandemic, particularly to healthy women who are not patients, who are not sick, and have no reason to be brought to a hospital to give birth. And yet, most of response around the world, with little exceptions, have been centralizing births, all births, in obstetric units. And I was mentioning earlier my great colleague from Bergamo. At the very heart of the pandemic, I was very early on in the pandemic in continuous contact with her, and it was completely tragic what I was hearing. but also really worried. And we are talking here about probably early first half of March, before anything hit in the UK. And from one side, I was like, oh my God, UK, why are you not preparing? Why are you not taking this seriously? And from the other side, I was hearing my good friend telling me, look, we have all these women coming to hospital, healthy, they have no COVID symptoms. 5 to 1 week, 7 days after birth, they're all positive and they all develop fever and they've all been infected in hospital. So now I was like, wow, this really influenced my approach to the situation. And I think, moving to England and the response in the UK, I think, from one side, there was the non be prepared for it. And I think there was a degree of panic in the response. So we've seen responses from various bodies in terms of centralization of services. Of course, there is variability there, but generally speaking, there has been a lot of cutting down of midwife-led services, particularly in the community. And we have seen some amazing examples of leadership where services were maintained by, for instance, hiring a private ambulance service. And we know that only 1% of the transfers need to happen for a real emergency. And actually most transfers can actually happen with a woman's transport. So, there were ways around avoiding the centralization, but in a way, I think this panic mode has in a way showed the true colors of what the service believes is core and essential and what was not core and essential. And home birth and birth centers were considered not essential. And this for me was a huge learning curve and really opened my eyes in terms of where we are culturally, how we still perceive midwife-led birth settings. So I started really getting, very, very early on, we are talking early March, getting really into studying all these aspects. So I got to this document, which is for the US, but actually the lessons learned are really widely applicable. And one of the first things they say in terms of response to emergencies and how care for women and children really suffer under emergencies, because most of the decision making is made by men. And in the whole decision making, women and children are kind of forgotten. I will never forget looking at all the expert groups across Europe. Basically, women disappeared overnight from those groups. Italy, all task force, everyone a white man. I call it pale and male. Really, really shocking. So, and so we started also, I started receiving calls from Italy and from Spain about really serious breaches of human rights of women, children, and birth supporters. Women being forced to have cesarean sections, forcibly separated from babies. Women not allowed to push, so routine instrumental birth introduced in some Spanish hospitals because the staff were scared about letting women push because they could infect them. Okay, so we are talking about serious stuff going on. And then I was very pleased to see the response from the ICM. Sorry, I'm moving forward. Whoops, sorry. Thank you. So we started really having a lot of response and activism there, including ICM, birth rights, and we also did a position statement. And really, again, the surprise for us there was that a lot of the suggestions, including the creation of pop-up birth centers, was totally ignored. And it was seen as something totally unrealistic. And, my question today, and I'm asking this question to the audience as well, why should creating pop-up birth centers in hotel, which are an ideal place for women who are at low risk to give birth, why was that not a viable option? And why are we not considering that seriously across Europe as part of a response plan for a new wave or the next pandemic, if it will happen. So for me, really, the main concern was to see the response and how really midwife-led services became part of the choice agenda, which can be disregarded, but were not part of the safety agenda, which for me instead was crucial, because keeping women out of hospital during a pandemic is fundamental, because we're talking about healthy women who don't have any pathology, and they needed to stay out. Sheena, I'm so sorry.
No, it's okay. Don't worry, it's absolutely fine. I just wanted to mention this is being published today in the Practicing Midwife. It's open access. I'll send the link through to the team afterwards so it can go on the Facebook page. But it's a scoping review that's been done of everything that's been going on and getting the balance. Are we asking the question, are we getting the balance right? And it's Sue Down, Jill Thompson and Anastasia Topolopoulou. And they've written this brilliant review, and we're lucky that they've done it for the Practicing Midwife, and it's going to be, and it's open access. So yeah. Just to finish, we must remember always that this is about both and, not either or, because we very often hear that it's either one or the other. It's either safety or it's experience, but it isn't. It should be the same. Good outcome and a good experience, both the woman and her baby, not the baby trumping the woman's choices, both the present and the future, because a lot of what we're doing has implications for the future. Both medical care and support for physiology. We have to respect both things, both honesty and a recognition of the complexity of healthcare and problems. And that's Sue Down's words and her concept that she's always talking about, both and, not either or. So thank you very much for listening.
Thank you.
And thank you very much, Sheena and Lucia. Thank you. I know that's it's a huge area, and there is a huge amount to discuss, because I know this has come into other weeks where people have talked about locally birth centres being or midwifery-led units being closed down, and care being pushed towards the acute sector, just as the home birth in some places was suspended. And I think increasingly in a lot of areas these are coming back, but of course some of the midwifery-led units will have been used for other things in the interim, so that it's very complex. And I guess in fairness, it's been a very difficult time and something nobody was expecting to deal with. So I think the learning has been incredibly huge all the way through. And I think the giving birth in a hotel, I mean, it makes absolute sense, doesn't it, really? As long as the hotel have got enough facilities and they're not tiny, tiny little uncomfortable rooms. Like, you know, it would have to be a nice, more luxury hotel, I think. I was being a bit superficial, I know. Anyway, we have a little time for questions and answers. And I'm looking this way because on my other screen, this is where the questions are coming in. And I've got Jenny Hall. Hi, Jenny. And she says, what would you say to midwives who want to enable women to have their choices, but local policies are preventing them from doing so, e.g. Induction, etc.?
Yeah. So do you want to answer that, Lucia?
Oh, go on, Sheena.
Okay, so Jenny, you're saying if midwives really want to support, I suppose at the end of the day, it's what the woman wants. And if a woman says that she wants to, she doesn't want to be induced, or she wants to give birth at home, but the local policy says she can't. And I suppose you're saying then the midwife. What would you say to midwives who want to support women? Well, actually, midwives have to support women's choices. So I would suggest that they, first of all, speak to a professional midwifery advocate or a midwife, a senior member of their team, to explain that this particular woman has got all the information to make her choice. She's made a rational decision, and this midwife wants to support this decision. And if there is no solution to that, if there's no local solution and there's no support for the woman and the midwife, then I would suggest that she approached Birthrights organisation to get some really good information on the importance of respecting human rights. And then I would go back to her manager and present it. And if that isn't successful, then I would go to the chief executive of the organisation and present it to the chief executive. But as a midwife, I think that we've got our professional duty is to support a woman's choices safely. And that is a key point, because we always have to ensure, first of all, that she has the information, and secondly, that she's got the right expertise to support her choice. So I think that's a huge responsibility as well. And sometimes, sometimes it can go, you can have, sort of radical kind of decisions on one end or too prescriptive on the other. We have to be in the middle. We have to be competent practitioners. We have to listen to women, listen to what it is they want, and then try really hard to facilitate that choice, whatever it might be.
Okay. Lucia, did you want to add anything to that answer?
Yes. So I would say I think sometimes is a little bit of a dilemma, and I would like midwives to consider this from their individual perspective as practicing midwife, but also from the organizational culture perspective. And as much as possible, I would recommend not to get into a fight or in a confrontational situation as an individual, because as an individual, we are quite vulnerable, but to create momentum, to create discussion, to create a group which then in a stronger way can challenge the system, and always do it in a positive way. Also sharing, if you support any so-called out of guidelines plan, ask the woman to write a positive feedback to the chief executive, to the head of midwifery, to really spread thanks so much for supporting my choice. So really build on the positive consequences of supporting choice, involving service users, because very often service user can say things that us as employees cannot say. So create a group rather than going into a personal fight, because there is an emotional bill attached to these fights, and in the long term are not viable.
And of course, there's the use of social media, which the social media and media itself, the positive stories perhaps don't sell as many papers, but maybe they should sell more papers, because that image of your niece was so beautiful this year. That would sell a whole raft of papers for me. Beautiful. Okay, that's beautifully answered. Thank you. I've got a comment from Carlette Simans, who says, it's a comment rather than question. She's suggesting out of guidance is much better phrasing than against advice, because it's their choice after discussion. That's a good comment. That's a nice way of putting it. Thank you.
I think it's quite nice maybe to call it a personalized care plan, because again, out of guidance is out of the rule. So I think we can find positive ways of talking about this. Certainly better than against medical advice, which is absolutely awful.
Yeah, that's a very slightly old-fashioned and rather threatening kind of comment, isn't it? Well, we've got Sonia Richardson. Maybe Airbnb should offer a birthing opportunity in emergencies. And there's a little smiley face on that one. So it's not beyond the means of possibility, actually. Okay, and Kate Woodcock, this is a question for Lucia. Did you have a CTG machine in the Barkentine in the event of abnormal auscultation? I ask this in order to prevent unnecessary transfers as in the case in the birth centre I work in. Thanks.
Yes. So this is something that is being discussed a lot. So the Barkentine, absolutely not. And the Barkentine is fairly close to the obstetric unit. But generally, the approach here is, if you have any doubt that you are moving outside the remit of normality, and you have discussed these, within your team, so you have a second opinion, then, having a CTG there is not going to make any difference, because you might still want the input from an interdisciplinary team, which is not present at the birth center. So normally the recommendation is, if you have any concern about fetal heart, to transfer, and then a CTG then can be done on a labor ward. And, roughly a third of women transferred still have a totally normal birth on the labor ward. A third has an instrumental birth, and a third has a C-section. So really, this system works. And I think when we start mixing up practices, then we go in an uncharted territory, because we don't really know what the unplanned consequences of having a CTG on a birth center could be. So that would concern me. Of course, we need to be flexible. So I spoke to midwives whose birth centers are really remote, in very, unfriendly geographical areas. So of course, I think, there needs to be discussion about those places. But I think there needs to be a very good thinking about what the unintended consequences could be.
No, that's great. Thank you very much. That's really useful. Okay, now I've got top fan, Jackie Cruz. Hooray for maternity voice partnerships who are great at giving voice to local women and also support midwives. So that's a comment, I think, and a little sort of clap all round, I think. That's fantastic. I mean, I was quite interested, Lucia, because I know you were talking earlier about, and Sheena too, about places where midwives are having to really struggle to bring in normality and be able to practice normality and support physiology. And it sort of floated in my mind that the difficulty you might have is, one, getting the confidence in getting that care, and two, with the women who may think like the medical model is the one, is better, is shinier, is safer, and all of those things. And I just wondered how you address that with your network. I know some of the answers.
Yes. So, since I got into midwifery, I studied anthropology before, so I'm really, really interested in culture in general. But since I started learning more about midwifery, and I've experienced it, in first person, the discrimination, and I think is the gender discrimination, and there is the professional discrimination linked with the gender and societal discrimination. I am studying a lot about movements for civil rights, particularly in America, but also in the UK. And I think, a lot of the struggles and the amazing work that has been done and is still happening in order to bring justice and equality. I think, we can learn a lot from that, because these, not having your voice heard and having to fight from a very unequal position is a real difficulty. And I think, we've seen in the last few weeks about Black Lives Matter, the impressive, development of the movement, and how much courage is there. And I think we need to learn from there. And I talk a lot about this when I go around Europe, particularly when we move in East Europe. The violence against women that we observe on a daily basis is quite shocking. And midwives and obstetricians can be criminally persecuted for supporting women's choices. So we are going well into the activism and human rights arena. So I think as midwives, we really need to learn so much more from outside midwifery, because there is so much about that political aspect and struggle aspect that we really need to be confident with. And until we really realize if we get into midwifery is a political thing we're doing, then we'll always be underneath and not able to make our voice being heard.
I think that's a fantastic point, actually. Thank you. That was really very important for us to get into politics with the small p and it goes back to what Sheena was talking about earlier about courage and being brave, because it's actually even in the UK, where we have so much advantage, we still have to move, we still have to change, and we still have to look at our practice and what we're doing and be courageous, and we must be politically aware. So there's still some way to go, isn't there?
Absolutely. As a young girl, I thought I didn't need to be a feminist. And the older I get, the more I believe I need to be a feminist, because the rights that we have, what we have gained in terms of rights, they can go back, and we can use them.
Yeah, absolutely. And I agree with that. In fact, I was talking to Sue Down the other night on a walk about that, and we were saying how that we still have violations of our human rights. We still don't have equality, and we can't stop kind of fighting for that, I believe.
Yeah, you're absolutely right. I think I've got one more question, and I know we're running out. This hour just flies by every time. This is Kate Woodcock, who says, "What is an alternative word to use for low risk?" I hate using the word risk. Thanks. Well done, Kate. Thank you for that.
Well, I think using wellness instead of risk or chance. If you're talking about the word risk, then in context of whether you're going to have a 1 in 2 in 1,000 chance rather than 2 in 1,000 risk. So you can use chance there. I think rather than focusing on risk, we should be focusing on wellness, and looking for, using a salutogenic model really, and looking at what works and what wellness means, and what the benefits of that state of, that kind of a sense of coherence within a woman, and what benefits that has. And then I also think, with that, instead of using the word low risk in terms of a woman's status, we should be saying that without complications, uncomplicated pregnancy. What do you think, Lucia?
So I normally like to use healthy women with straightforward pregnancies.
Yeah.
Because uncomplicated, again, we focus on the complication.
No, that's right. Yeah.
But of course, it's a bit more of a mouthful. So this is always the dilemma when we write articles. We keep saying healthy women with straightforward pregnancies, but I prefer to use that. So it's. But I think as long as we keep, having that conversation, and with our colleagues, trying to really watch our language, because language is so powerful.
Yeah, it's interesting because Sherry Jean Louise has said we've been taught at universities to say less chance. Good.
Less chance, yeah, brilliant.
Good. And on that point, I think I have to bring it to a close because we've run out of time. And I'd like to thank Matt Flix for the video content from Maternity Expert, and our partners who just happen to be the Practicing Midwife Journal and All for Maternity, with our online resources, wonderful resources for you. Remember, all of these resources are on the resource list, including the Raw. Very good reading. You don't have to read it cover to cover, but you probably will. And I'd like to say a huge, huge thank you to our wonderful speakers, who I think might well be on social media after this, answering some questions if you had any more questions. And the resources will be available on the website and on Facebook by Friday. So this whole presentation today will be available after today, but it takes a while just to unpack it and get it kind of sorted out there. Now, next week, the Maternity and Midwifery Hour on Wednesday will be BAME perspectives from the front line, and we have Mala Morajaria, who's nurse practitioner and midwife, and Lola Ornato from Whittington, who also midwife. So that'll be a really interesting, very timely discussion. We've got the Midlands Festival on the 14th of July, live and on demand, so book now. And in the meantime, to all of the people who've joined us, thank you for joining us, and stay safe and well, and we'll see you next week. Take care.
Thanks for watching this video from the Maternity and Midwifery Forum. For more expert opinion and analysis, hit the button below to subscribe.